Okay, welcome everybody to our oversight and accountability session this afternoon. We are taking up conflict-free case management and payment reform at the Department of Disabilities, Aging and Independent Living, and we have a slew of guests. And the first thing that we are going to do is to take a quick look at Act 186 of 2020. And you can find a copy of that on the committee's webpage. I want to specifically call your attention, and you can put that up on the screen, Lori, if you're able to. Specifically call your attention to Section 6. This was a bill that dealt with our DD housing initiative and the pilot projects, the 3 pilot projects. It also dealt with the establishment of the limited service position for residential program developer. And also dealt with payment reform and conflict-free case management. So it was kind of a bunch of different things. There we go. So if we can make it a skosh bigger. Perfect. Part of our oversight and accountability is related not only to the ongoing work, but we also highlight it back to the originating legislation that the body passed. And as I said, this was from 2020. And I'm just going to go through because there are some things here that wanting to, whoops.
That was me.
Okay. All set. We're all set. It's all good. This section 6 at the bottom of page 8 and the top part of page 9 deals specifically with the requirement to seek approval from the General Assembly prior to implementing a system-wide payment reform and conflict-free case management. And looking at the standardized assessment utilized by the department and a process for considering additional information relative to the life circumstances of the recipients or applicants. Looking at, in addition to any standardized rates or rate ranges developed by the department, a process for consideration of budgets to reflect the individualized support needs of recipients or applicants, and a process for evaluating the fiscal and service impact on individual recipients and the designated and specialized service agencies. And prior to implementing the federally required conflict-free case management system, the department shall seek and consider input from a variety of stakeholders, including individuals with developmental disabilities, their families, the DAs and SSAs, and other providers and advocates, and seek approval from the General Assembly. As part of the changes necessary to come into compliance, consideration be given to performing initial clinical eligibility and service planning within the department. So this was a bill that was passed in response to a lot of anxiety by community members and by providers, and to provide some baseline, essentially, baseline for assuring that these issues receive the full support and oversight of the General Assembly, because they have far-reaching ramifications. Any changes to the payment system or case management system deeply impact individuals, the staff that support them, the providers, the department, all along the way. So with that, I will turn it over to the department. That's just sort of the background of where we're at. Thank you, Lori. That's the background of why we're doing what we're doing today, and the ongoing process of implementing changes that are as big as this, as you can see, take a period of time to implement. So that was closing in on 5 years ago now. And Okay. Not sure what that was.
It's a.
Somebody has their sound on.
Can you
Todd?
guys mute?
Do you have your sound on?
Me? No. Not at all.
Rebecca.
Okay,
I think it's Rebecca's not muted.
okay.
It's like it's fixed.
We'll say,
Rebecca.
it doesn't look like you're muted, Rebecca. Okay, well, we'll figure it out, or somebody will figure it out. So Commissioner, welcome to today. And as you can imagine, there's a lot of anxiety about the changes that are happening and really wanting to understand the implications for those changes. And as I mentioned to you, one of the several times that you've been here already, we're starting to hear from family members about changes and hearing from providers about changes and the sort of a little bit feeling like the plane's being built as we're flying it, which when you have big change like this, it's an iterative process. I realize that. So welcome. Not sure exactly what you have ready to present, but I'm sure that we will have questions as well. And I'm not sure if the floor is yours, you can designate who you would like to speak.
Okay. Thank you. For the record, Dr. Jill Bowen, Commissioner for Dale. And with me are a variety of subject matter experts and leadership through Dale. And if we could just introduce, do you want to just say your name? You're here.
Angela Smith-Jang, Deputy Commissioner. Center for Developmental Disability Services Director. Our new principal assistant at Dale.
Let's go on the screen. I'll call you, okay? Angela?
Sure, Angela McMahon, Interim Director of the Adult Services Division.
Dylan?
Hi, I'm Dylan Fraser. I'm Deputy Director of Medicaid Policy with the Agency of Human Services. I just want to point out the agenda had me down as being with the Department of Disabilities, Aging and Independent Living, Dale. But I'm actually with the central office of the Agency of Human Services and here in partnership with the folks from Dale, we've been working closely on this effort.
Thank you, Dylan. Although, we love you if you want to. Stuart?
Hi again, folks. Stuart Scher, General Counsel.
Yes?
Hi, I'm Jeff Nonamaker, the Developmental Disability Services Division Assistant Director.
Thank you. And I said Jess before, but Jessica?
That happens all the time. I'm Jessica Bernard, Deputy Director of Payment Reform with Department of Disabilities, Aging and Independent Living.
Yeah. Erin?
Hi, good afternoon. Erin Flynn, Deputy Director of Payment Reform with the Department of Vermont Health Access, also known as DEVA.
And Alex just joined? You just introduce yourself or just introducing?
Hi, good morning, or good afternoon, rather. Alex McCracken, Director of Communications and Legislative Affairs for the Department of Vermont Health Access.
And then we have Rebecca's puppy. So so what I'm going to do, we have a presentation for you. Do we have it up, ready to go? We have a presentation for you. We're trying to provide a comprehensive view into conflict of interest and payment reform. And I know that we have limited time, but you then will have this document as well, and we can answer any questions. Yes, it was a broad, that's why we have folks here from who were participating in this effort. Clearly, this was well underway before I came here. You highlighted 2020, 5 years in the making, but here we are on the kind of the final runway. If we're going to keep the plane analogy, which is appropriate, I think. So we're going to start with conflict of interest. It's up here now. Let's go to the first slide and start to walk through it. You will see that there is a fair amount in what you had just brought up in the summary of the bill that was clearly adhered to in terms of inputs and regular meetings with people in the field, families and individuals and advisory groups representing across the board. And I think most importantly, the providers who were very, very actively involved in the process. So we're ready to go. Let's start. I will take us through CFI with help from, and feel free to ask questions as we've done in previous testimony. Just we can have a conversation about anything you have questions about. And then Jessica Bernard will take us through the payment reform overview. The components of conflict of interest, as you see up there for developmental services. And I think you know that for those who don't know, conflict of interest is a requirement by CMS. We were out of compliance and cited as such. We have a timeline within which we must comply. And it affects developmental services, brain injury program, as well as choices for care. So you'll see a little bit like, here's developmental services, here's choices for care, just so you understand why we have sort of two slides that look somewhat similar. So what are the components of conflict of interest for the developmental services? They include independent intake, eligibility, and referral. That's how we get conflict-free. And it's moved to a centralized approval. The independent needs assessment, again, it's a standardized norm reference to that's called the CISA for folks who are 16 and older. There's also a standardized assessment for brain injury program participants. There's also an assessment for those under 16. Separate case management activities from service coordination. That's notable for person-centered planning and ISA development. Alignment with the state's philosophy and core values, especially around person-centered, respect, leadership, and ultimately results in compliance with federal requirements.
So Commissioner, okay, looks like you're going to go through each green area. I'm not looking ahead of yours, but I just noticed when you flip to the next.
Well, what this slide is choices for care.
Oh, and choices for care. Okay, so can we come back just for a moment then?
Yes.
Move to centralized approval of independent intake. So intake eligibility, been previously done by designated agencies. And
can you pull us?
oh, okay, so you're moving to
Yeah,
you'll have details on each one of these little bullets.
we will.
Okay.
And so maybe we'll come back to that.
I'll wait then.
Okay, so now we're just doing that same components, but for choices for care. Again, it's an independent intake, eligibility, and referral. This time, the Adult Service Division, registered nursing staff, the long-term care coordinators will do that. The options counseling is provided by the state LTCCC or LTCCs. Referral to the local area on aging, the AAAs, everything's got to be a triple something. And the enhanced residential care for the nursing home. And then an annual utilization review to ensure continued eligibility. Independent needs assessment. The case management agency is using the ILA for this population, the approved assessment tool, and that develops a person-centered care plan, and the ISAs, the individual service agreements, for all choices for care and brain injury program participants. And then, of course, separate case management activities. And again, person-centered planning, development, independent options council. So now if we go to the next slide, I think is what you were looking for, Madam Chair, which is the breakdown. So this is the changes to developmental services around intake eligibility. Conflict from the designated agency, the intake eligibility and referral. Working to develop an independent centralized contract for intake eligibility and referrals, and the referral to the case management entities, and eliminate any bias related to intake and eligibility. And that will ensure standardized and impartial referral information for referring individuals to case management options.
So is the department going to be, so like with the LTCCs, they're state employees, they're doing intake and eligibility determination with state employees essentially. Do you plan to do that with state employees for developmental services? Or you plan to contract that out with a separate entity?
Contracted.
And so is that entity will do that for, so right now that's divided up among 10 different designated agencies, and I'm not sure exactly how many new people or new applications there are, but what are you anticipating that contractor to be able to handle in terms of volume?
Estimated it to be about 300 annually.
And how is that being paid for?
Conflict of interest has a budget that's in
The
8.6.
Yeah, so that includes the eligibility and the assessment piece of it. So it includes the CIS-A as well?
No, this is a separate contract.
Okay,
What's this say?
But under the same money funding stream? Or different funding
No,
stream?
that's-
That was a different
that's
funding
already
stream,
been-
because it's already been in place. That was already in place.
that's right. That's been
Mhm.
ongoing now for a bit. Okay. So are there any, I know there's been some concern from both service providers as well as family members about budgets being reduced in order to fund this new layer in the system that's independent now. But I was happy to see in your, I mean, I wasn't, I'd rather be spending it on something else, frankly, but of seeing a separate budget request to fund that. So is it fair to say that there was not any reduction in designated or specialized service agencies or individual budgets in order to fund this, new independent case management and eligibility process?
Yeah, so we've been working to really clearly message that this is a separate component, that it could not affect the services that individuals receive. Certainly, we've been clear to articulate that, we wouldn't know anything until the governor's budget was released, and that's a starting point in the budgeting process. But that we've been clear that this needed to be something separate, and we didn't feel it could come off the backs of people's services.
Representative Steady.
What was last year's budget numbers? You said 8.6 million this year. What was it last year?
8.6 million is for conflict of interest implementation, is this year.
So this is all new?
Yes.
Yes.
Okay. Thank you.
There are questions around this?
I
You
got
asked
it.
about,
I
you got it.
got it.
Okay. SIS is supports intensity scale for members. That's, again, a relatively new process. It's an independent assessment that is been in place now, what, 2 years? I don't know. How long?
Since the summer of 2021.
Interest money come.
A global commitment.
It would be.
Is now Medicaid is global commitment?
Global commitment is,
That is Medicaid.
Is Medicaid? Okay.
it's the waiver.
It's a waiver,
Global
so,
commitment 1115.
so mostly federal then?
It's a combination.
Yeah.
Global commitment is a combination.
So it's about 60-40 or,
It's more like 55-45 now.
so it's pretty close.
Yeah, it's almost 50-50 at this point in time, but it's like 55-45.
Good, thank you.
Yeah.
Appreciate it.
Should we go on to the next one?
Yes.
This is the same kind of breakdown, but this is specific to Choices for Care. Separate annual assessment and person-centered care, separate annual assessment and person-centered care development from the role of the Adult Family Care and Flexible Choices Agency. Case manager coordinates the annual assessment with the participants' team and provides choice counseling for all Choices for Care, home and community-based services, settings, options. It eliminates again the perceived or implicit bias related to continued eligibility and choice counseling coming from the service provider. will ensure standardized and impartial referral information referring individuals to choices for care option. Next slide. We're gonna just look at the new developmental services independent needs assessment process, which isn't so new anymore, but this is it's the supports intensity scale as you noted. What that does is ensures that the entity providing the services is not the entity that's assessing the needs of the individual for services. It establishes an independent needs assessment process. And it was established back in 2022 by contracting with an outside organization. So 2021, I guess, was beta testing, as you say. And independence of the assessor removes the potential for partiality.
So so while that's been going on for now 2 or 3 years, I think the part that's new and is now starting to, I think, raise the concerns is the connection of the CIS-A with the money aspects. And I don't, and maybe you're going to get to this. So if you are, like, how we go from the CIS to an individualized budget? Because clear that we wanted to still maintain the ability to have individualized budgets within parameters. If you're going to review that, then I'll just.
Yeah, because there is some. The payment reform and COI are inextricably linked in certain ways. And so we need to go through the whole thing for you to see how that lines up. But the CIS-A does lead to the information about tiers and budgets. So that's how that will come to be. Case manager roles and responsibilities. The case management separation here is key. And this just gives you that was the next slide. Oh, okay. So here's what the case manager does the assessing and planning. That's the person-centered planning process. And also identifies and links to supports. So the provider agencies, choosing the support provider agencies and the types and amounts of support. Coordination, that they support collaboration, facilitation of individuals, facilitate team meetings, problem solving, and any changes that would be occurring to their services. They monitor implementation, satisfaction, health and well-being, and service utilization, and they're an advocate for the individual they serve.
How many caseload? What's the caseload size expected?
Yeah, we expect it to be between 30 and 34. That is
Really low compared to the field.
Oh, is that?
Yeah, I know
That's not really low compared to what people do now.
so, right, you're absolutely right. Currently, service coordination is a more comprehensive position, has caseloads. I think they used to be around 12. Now with the workforce situations that we have, they probably, looking at my colleagues from PCP, probably trend more towards 20 per person. A caseload for a case manager of 30 to 34 is significantly less than what we've heard that happens nationwide, which trends closer to 100. So putting in an expectation in our request for proposals and then subsequently in our contract, because the expectation is around 30 to 34 is, it's pretty significant and keeping with our state values.
Is that what you're expecting in choices for care as well?
Yeah, Angela M.
Yeah, sure. Choices for care is a little bit different because if there's a case manager who's case managing only in our moderate needs program, that caseload can be a little bit higher. So traditionally, the caseload policies have been between 35 and 50, but it really depends on the case manager and the caseload that they're covering. So we're anticipating not above 50, but it really does depend on the acuity of the individual and the program the person is, providing case management for. Many case managers serve only moderate needs, and many serve individuals in all different programs.
Well, I mean, everybody's required to have a to have case management. So it's not just moderate needs, it's high and highest as well.
Yeah, but I think what she's saying is if it's high and highest, they may have a smaller caseload than moderate needs would have.
Larger
Right.
case.
Moderate needs would have a larger caseload. Those that are serving people in highest would have a smaller caseload because of, there's more work to do for each individual. Their needs are
Right.
more.
And we authorize up to 24 hours of case management and moderate needs and up to 48 hours annually for highest. Of course, there's, opportunity to be authorized for additional case management on a case by case basis. But traditionally, the moderate needs clients have required fewer hours of case management. So those caseloads have been a little bit bigger.
Representative Steady.
I'm not sure if I'm way off, because this is all new to me. This is a budget, right? So I put, how much of the 8.6 million is administrative costs versus client care? Or is that coming?
No, we did that.
So that, this actually is not a budget meeting.
Oh, okay, okay, then I'm all set.
But we did present that. And you should
I'll
have,
find it, I'll find it.
It's in the.
I don't want to take
in the
away.
Dale materials from Friday.
Friday, that helps.
Okay.
Thank you.
yeah, and it's broken down
I
easy to
didn't-
find. It's actually quite easy to find what's
I
administrative
don't want
and,
to take up this meeting.
yeah.
Representative Nielsen, did you have your hand up before?
I did, but she answered my question.
She did. Okay, thank you.
Thank
You
you for
wanna-
recognizing me.
I want to make sure we have time for the payment reform piece,
Yeah.
because it's going to tie into, I think, some of your questions. So, so the expectations for brain injury and developmental disabilities, you'll now see brain injury and developmental disabilities sometimes together because they are using the same case management entity. Okay. So frequency of visits are based on need, required to have at least one in-home visit annually. Case management entities or statewide organizations must have in-state presence. Case managers must be located within 60 minutes or 60 miles of the individuals that they support. Right, within, so no further. Caseload sizes will vary based on the needs of the individual supported, which is just what we were, the same concept we were talking about. So that now we'll do the choices for care. Those are the AAAs. The 5 AAAs are providing the case management to all CFC participants, and that process is underway. They're shifting over to, and about 60%, I think, have already shifted. Frequency of visits based on need, required to have at least one in-home visit annually, and caseload sizes vary. This is exactly what we just discussed. So so the next, I think this is an important slide because what you were raising when you said what they're getting now versus what they would be getting is a little bit of apples to oranges in that the current situation is that the case management and the service coordination is tied together in one. So one of the efforts here is to separate those two. There will still be service coordination or program coordination, but now the case management aspect of it will be out here. So that's, you should say, it's like this, and then you go like this. That's what a big part of what this has been. And so to just take a look at what the service program managers will continue to be doing. And those folks are, many of them work at the agencies, they're designated agencies. They work there now and they would continue to work there, or they would hire folks to do this particular role. Moving to program management. Flexibility to meet each agency's specific needs. They're focused on the supports provided within the agency. They provide hiring, training, and supervising of staff, they monitor shared living homes and SLP contracts. They also ensure direct support staff are collecting information related to outcomes in ISA. So these are folks that are already part of the designated agency that they are working with. Okay, so major goal, achieving federal compliance. So just to highlight this piece of it, because it is a driver, is that Vermont has been working on a plan for 10 years. One of the last states in the country to meet the requirements. Under a corrective action plan with Centers for Medicare and Medicaid to meet the requirement, and we must come into compliance by May 2026. I just want to say out loud that the program that currently exists is a good program, right? So it's, you just want to try to look at this evolutionarily. You build on what's good about a program. You do your best to keep the components of it that are effective. And so kind of want to see this evolutionarily because there was a lot of good that was being done and it is being done in that system. But there is not an option to not move in this direction or to evolve in this direction. And so this program is, yes, a long time to build, but kind of literally like the last one in the country to move in that direction, probably because you did have a program that was working and there was an effort to try to forestall it, but here we are. And our deadline is what it is. Next slide. Brain injury and developmental disabilities conflict of interest. And here's the current timeline for the DD and TBI. So you will see, starting to look at it from 2025, this is where we are currently. Like, yeah, we can start out there with the timeline, but we'll just start right here at the timeline. And so quite a bit has been accomplished and is continuing to be underway currently. February is now. So the number of case management entities that coming from the procurement process, and beginning the contract process, that's all underway. The executing the contracts and announcing the case management entities. We expect to be able to do all that in April. Then by May, we're going to do open houses to meet the CMEs and begin the enrollment processes. By June, we will have enrolled. That's our deadline. Transition meetings in July. The initial CISA assessments are complete. They've been rolling for a bit. The initial CISA assessment should be complete by July, and funding assigned based on the CIS score. September, by the end of September, the transition period ends, and last day for service coordination to be encountered, the encountering process. October 1st is case management begins as a billable service and service coordination converts to program management. Those are the two components now, management and the program management. And then in December, the transition process further ends. I don't know why it ends twice, but anything that hasn't ended in transition.
You really need that.
That's transition for you, actually. I'm sure there will still be some lingering pieces that need to lock down by the end of the year. There's transition grant funding. This was really a direct request from the providers and something that we initiated. When I came here, we began to have some conversations. They needed transition funding in order to be able to do this. And so that is in play, right? So they are receiving the transition funding.
There's grant information will be going out soon.
Okay, so it's on its way to help with these pieces that I just said are all going to happen spring, summer, fall, and then by April 2026, we have to be in full compliance. That's that deadline. On the next slide, you'll see.
We're gonna skip over that one.
Yeah, it's another way of representing the timeline.
So we just did, yeah.
And so this is just this is basically two slides that just sort of highlight, right? So we're meeting the federal corrective action plan and we're separating entities to provide intake, needs assessment, case management, and direct services.
Yeah, go ahead, Representative Garofano and Representative McGuire have a question.
Thank you. So I'm just wondering about the funding assignments in July 2025, when the SIS-A is starting to be used. I'm wondering if you have something, or it's already being used.
Right. Mhm. SIS-A will be wrapping, or everybody will have gotten the SIS-A by.
So July 25, initial SIS-A assessments complete and funding assigned based on SIS-A score.
Right, so everybody's getting an initial SIS-A, but that's going on even now.
Right, so I'm wondering, are you, like, is there something built into if there is a huge discrepancy of what someone used to get and what they will get based on this? Is there something built in to kind of track that, to kind of highlight, whoa,
Yes.
like their funding went from, 50,000 to 10,000?
Yes.
Just as an example.
So first, a couple of things. The initial read on that, based on what we have, the information we have right now, is that the vast majority will get the same level of services. It's like 87 or 88%. Jackie, just jump in. I mean, Jessica, just jump in if I have that wrong. But it was about 87 or 88% that appeared to be where they were going to get the same. Then there will be some who will get fewer services than they're currently getting, and others that would get more services, all based on this SIS-A. So the SIS-A is pretty consistent and providing about the same service for most people. So we're not expecting to be really far off. On the other hand, exception process is very important in this, right? So there is a way to address if something is off, like, yeah.
And we'll get into more details during the payment reform slides as well, so we can talk through that. There is a little more detail to it than the SIS score, the budget. There are other things to build into it as well.
Like the context piece of it, right?
Exactly.
The context piece of it is something you highlighted in the bill, Madam Chair, and that was built into the process. So there is that piece of it, which helps sort of further individualize. So the next slide just wraps this portion of the presentation, and just the focus of transition. There are transition grants for both incoming case management entities and existing direct service organizations. There's continuing ongoing meetings with providers. They're very regular. They're happening all the time. I think the last time we were here, Jessica came late because she was doing the exceptions process work with the providers. I'm pretty sure if we run late, Jeff, who's on here, the Jeff person, he's working with the Conflict of Interest Advisory Committee meeting today. He's participating in that. So there's a lot of work and a lot of avenues that aligned with what the bill had required. And then expanding communications with individuals and families. So working with the providers and hearing about concerns that they were getting from families and some of their own ongoing questions, we began a process. The first mail out was sent for the families, was sent through the providers. Subsequent mail outs to the families will come directly from Dale. And then a communication packet and guide went to the providers to help them to be able to communicate effectively. And so we are very much in our expanding communications process, because everything that you said at the opening about it being difficult and anxiety provoking and uncertainty in any kind of major sort of reform is going to need to have a good communications plan.
Just a minute, Representative Steady. I realized Representative McGuire didn't get a chance to ask his question before.
I'm good, thank you.
Very good. Okay, Representative Steady.
This is new to me. So is this new or is it just updating what's in place now?
Sort of both.
Yeah, I'm not sure how to answer. So it's both.
Yeah, I mean, it's a new process. We can talk more about that offline, Representative Steady, if that would be helpful.
Thank you. Yeah, it's just this new.
Yeah, I mean, services are in place.
Whatever is being reviewed right now is new to lots of people, so it's,
Okay.
yeah.
Okay, we're going to shift now to payment reform, and I think some of the specific questions you have will likely be answered. But I'm going to ask Jessica to do the walkthrough.
Yes, happy to. So we'll be talking about payment reform, and so we wanted to share some foundational information since many of you haven't been on this journey with us for the last 5 to 7 years. The reason payment reform is happening, it really started in 2018 in response to state audit findings. Our current DS payment system, it just doesn't have a standardized rate or needs assessment. So that meant we didn't have the ability to account for all of the services provided and the associated spending that came with it. So we weren't always able to say this person has this budget, gets these services, and this was the amount of money expended. And so that came back as a finding to us at a state perm audit. We also know that there is a lack of adequate direct care workers. It's affecting service delivery. It's affecting most agencies. And so, while we do have current payment monitoring systems, we're just not able to validate individual budgets and services or track outcomes without some of these changes that we're proposing to make. Some of the changes are already underway, like encounter data reporting. So an agency says this person got this service on this day. So all of these pieces come together and are going to help us form a new model that's designed to support service utilization, help us show where the gaps are so that we can improve quality and hopefully improve service delivery. So our goals, we want this to be transparent. We really do want this to be easily described and understood by everybody who is involved. It needs to be effective. So we have to create a payment model that supports people getting the appropriate services to meet their needs. It should be equitable, right? Resources should be available in a similar way across the state. If someone has similar needs, you should have similar access to services. We also need to be accountable. So we have to be able to identify what services were delivered to people, and it has to be sustainable. We've got to be able to pay providers reasonable rates for delivering services. And so this is a really high-level overview of the future process. There are more details, but I think to try to make sure folks get what our basic building blocks are here. So people need to complete a SIS-A, that supports intensity scale for adults, and that's going to identify a level of support. And we worked with a contractor, Human Services Research Institute, HSRI, and they were able to look at people who had completed SIS-As, and we determined that there were 6 different levels of support in Vermont. And so once we knew how many different types of support, different levels were needed in Vermont, we were able to then do our budget modeling to look at budget ranges based on someone's residential setting. So somebody who has, let's say, moderate general support needs, and they live at home with an unpaid care support versus somebody who is living independently. Those two people may have similar needs, but their budgets are going to look different. And a big driver is where they're living. Because if you have an unpaid support that you're living with, you don't have kind of a residential cost versus someone who might need supervised living so that someone can be in the home to make sure that they're safe and healthy. So we have to take into account where somebody lives, their SIS-A level of support, and context. And so some of the context that we're talking about, we've come up with, so we have a context, what we call a standardized assessment work group that's been working on this context piece for, I think, about 2 years now. So we've come up with, I think, about 7 questions that we want everyone to be asked with their case manager when they make the transition, that we can use as flags to say, hey, this may be somebody who we need to take another look at. They might need more in their budget. And in addition to those flags that we want everyone to be asked and to talk about to make sure they're going to get the right budget and the right supports, there is a bigger context document too that we're working on, where we want to be able to have a really good flowing conversation if somebody wants to engage in it. We don't want to force this tool on anybody. But so that's one of the things that we're working on. So people can talk about, sure, this is what their life looks like now. Where do they want to live 2 years from now? Maybe they don't always want to live at home with a family member. Maybe they need to have a plan for support because they are living with a family member. Maybe there's a health concern, and that may not be a long-term residential situation that they can expect to be in 5 years. Maybe somebody wants to get their driver's license. Maybe somebody is hoping to work. So we want to also have these context questions that can accompany this person-centered planning process when someone's making their ISA. And then one of the areas that we're pivoting on, we've done a lot of that throughout the last few years when we've been working on payment reform. But one of the things that we've learned too is that our new case management entities may also come with context tools. And so we're working to fold that in. What does that look like for the case management entities? What do these tools look like? What are they asking? Let's compare to the work that we've done here in Vermont. And so that's a piece that is still going to evolve a little bit, but context is definitely part of the process and part of the conversation.
Jessica, the context group is inclusive of families.
Yes.
Yes.
Yes, we have DDSD staff, we have DIVA staff, we have families, we have individuals who receive services and providers. So it's a great group.
Thank you.
So those are the pieces that people are going to need to look at so that folks can take a look at the budget range that's going to come, that's attached with that level of support. And if we could just go back one slide, I want to make sure I get, thank you, all of the pieces of the process. And I'll try to speed it up because I know we don't have a lot of time. So that's where we're going to look at someone's budget range. Those budget ranges that you'll see a little bit later were made looking at the services that people receive now. And so what are the services that people are typically getting when they're in a certain level of support? And so we tried to create these ranges based on the services that we see people getting so that it would fit for most people. It won't fit for everybody. That's why when people go into that next step, the person-centered planning process, we want folks to be developing that ISA up to the limit of the budget range. Not everyone should just plan up to the budget range. It really should be individualized. So that planning is never going to go away. When folks are talking about what are the services that they need, what are the services that they want, what makes sense, hopefully it'll fit within their budget range. And if it doesn't meet their need after they've gone through they've looked at their context, they've looked at their assessments, they've done their ISA planning, they've looked at all the information that makes sense for them. If it's not going to meet their need, that's exactly why we will have the exceptions process. We know that there are folks who are just going to say, hey, this doesn't fit for me for whatever reason. And here's the process for them to ask for what they need. And so we're going to build that in so that hopefully, yes, during the transition time, it's going to be something that we anticipate will be a larger volume because so many people are transitioning at once. And then after that, because we hope the budget ranges will work for most people, it shouldn't be something that most people have to go to, but it's not a flaw of the system. It's actually, we build it in because, this isn't cookie cutter. We do want it to be individualized, and there is room for people to just explain what their needs are and why something else is needed to make sure that they're getting the supports that they need.
So Jessica, one of the things, I guess just listening to you, honestly, I'm getting more and more anxious, to be honest, instead of less anxious. And it's not having to do anything with the information you're presenting, but just the complexity of this we definitely are adding complexity to the system. And, perhaps some of that's warranted. I'm not sure all of it is, to be perfectly honest, but it does not feel consumer friendly to me, to be perfectly honest. And what I'm thinking of in the back of my head is, we have hundreds of people living in shared living with shared living providers, just to use them as an example, who have rates that have been paid to them, based on some history, whether or not they meet with the CIS A or don't meet with the CIS A ranges, there's probably reasons why they exist the way they are. And all I can picture in my head is hundreds of people having to go through this exception process as they begin this transition between what they've had for decades and what they are moving to, because we're implementing this new system. And while, I hear you say that after the initial part, it should level off, I think you can pretty much expect hundreds of requests for exceptions in a new process.
So I'm not so sure about that we are good. I think it's actually a little bit simpler than that. I think most people, like 87 or 88%, are going to have the same level of services that they have, but they will have gone through the CISA assessment process. They go through an assessment process now. It's not like they don't.
Right.
So it's not so strange to go through an assessment process.
Right.
And this assessment process has this contextual piece to it that's important. All of that is taken into account. And then you fall in a range. Most people are going to fall into a range that is similar than what they're getting now. It's an exceptions process is an exception. It just built in a flexible way to tweak and adjust. And it's not like that doesn't happen now either, right? Today, if you had exceeded your budget or you wanted something different or something has changed, you actually will go, there's a way to ask for that.
Right.
We understand that. This is more about person by person by person, the budget, as opposed to sort of aggregate at the agency. But I think from a person's point, what we want to have happen at this is that it's not so obvious to the person that something big has happened, right? That they're still receiving the same services. They're still eligible for the same services. There are going to be folks who, because of the assessment, are going to get some more services, and then others who, but it should be a small percentage of the folks who are going to need that exceptions process. We're planning it that way because it's based on what they're currently getting. And if I didn't say that properly, Jessica, do you want to jump
Yeah, I
in?
think I would just add back to kind of the earlier comment about things feeling more complicated. I would actually say what we're proposing is less complicated, because right now every single person has to go through a funding request. It has to be reviewed, it has to be approved. Under what we're proposing, especially for folks who the budget range is going to work, they're going to kind of go forward, continue getting the services they're getting. They no longer have to come to us with the funding equity committee. So it's going to be a much more streamlined approach. They still have to tell us what services they're getting. And, we do have to know what their budgets are and sign off, but it's no longer every single person has to look for an approval and could have, this adjusted and that adjusted. Folks will just get to kind of go forward and plan. And so we're really reducing the amount of people who have to come and ask, in this case, for an exception. And so we do think it will be a smaller amount of folks. And so I just want to make sure that, in case folks don't know how it currently works, we are really trying to step back the administrative burden on that process. And so that it's really, people can know what it is that they're planning for and go ahead and plan if it's going to meet their need. And then for the shared living providers, I think it's a really good and a very important point. The shared living provider stipends, that's one of the areas we've been getting a lot of feedback on, and that we do want to continue to get feedback on to make a final decision about, do we want to use the exceptions process? Do we want to consider other avenues to streamline some of those requests? Because I think you're right. I think that's an area where things have not been consistent, across the state, because every agency is a little bit different and individuals' needs are a little bit different. And so that's one of the pieces that we're very carefully considering. And so, of course, if you have feedback for us, we want to hear it about if you have a suggestion considering the future of the shared living provider stipends. Please, this now is the time But it is one of the things that we think is crucial. We don't want to make people anxious about their the future of their residential setting. And so, yes, we agree. It's something that we're very carefully considering.
Okay, I'm just taking a look at the time.
Yeah.
And just am wondering, I know you just really kind of started to scratch the surface here a little bit. And I'm just wondering if we should have you back, Jessica, and Commissioner, which we could do virtually, so you don't have to.
Mind coming down and seeing you. I mean, we're happy to do this. We understand that this is important. I think what I just want to highlight here before we wrap that, what we're looking for is consistency and flexibility. Like, it has been built in to both. So anytime an issue arises for us, like there's a lot of variability in SLP, rates and all that, that is something we look at. Again, how do we get some sort of standardization and flexibility? Because we certainly don't want to disrupt things that are working, right? That's not the point.
I hear you. And I think that we've been focused on the individual, which is where we should be focused, but we haven't really had an opportunity to discuss the impact on a designated and specialized service agencies. And so how, when we put all of these pieces together, does it, what kind of impact, and I know that there's I looked ahead in the slides a little bit to see that there's ranges, and then there's, sort of percentages that are allowed, and different rates being paid based on, certain percentage of fulfillment of a service plan, et cetera. So I don't want to lose that, but we don't really have time to kind of get into the whole thing right now. Should have anticipated there'd be a lot of questions about this.
Yeah, we did.
No, I should.
Oh.
I should have
Have the world here with
I
us.
should have anticipated better. So if we will definitely try to get you back in the near future, and just kind of pick up where we left off, if that's okay.
It's fine.
All right.
We're happy to do that. We understand that that's why it's, it's transformative. And it's not easy. We recognize that it's anxiety provoking.
Yeah.
We don't want you to be more anxious when we're done. We
Well,
want you to be.
and I'm trying to really honestly to figure out what form, when I look at the legislation, what form does legislative approval take? Because it says seek legislative approval. And so I need to ponder that a little bit. I'm not exactly sure what form legislative approval takes. So I need to consult with Leg Counsel about that a little bit. So I don't know if, approval of the budget is approval, I don't know. But since it specifically calls it out in two places here, I want to make sure that we're doing our due diligence as well, in terms of what the law says that we should be doing. So despite all of the questions, I really want to extend my appreciation to what I know has been a long road for people. It's been years, and a lot of work and thought and time and energy and attention to detail has gone into this, I recognize. And while there's lots of questions, there's always going to be lots of questions when you're making changes like this. So I appreciate your patience with that.
Happy to do it.
All righty. Thank you so much for being here.
Thank you.
Thank you.
Okay. So some of us will see you in person again.
Yes.
Some will be on the screen.
That's okay. That's good.
Thanks so much.
Thank you. Thank you very much.
Yeah, take care, y'all. Thanks, team on the screen.
Oh, they're signed off. They're going. They beat feet, as we say.
Interestingly, it says
Go ahead.
shall
I'm just-
seek
I don't want to
approval.
get in it, but.
Doesn't say they have to get it.
Yeah, right.
I know. I'm not sure that they, come on in.
And it's- the approval is.
Not sure that they really.
What, what are they, what exactly are we approving, you know, and you know, what would. Yeah. Exactly.
Here on the intent.
What, I have competition on the flowers? too?
Oh, those yours?
Yeah, mine.
These are leftovers from last week. I just cut them down and put them. in.
Oh, perfect, very nice. I thought I had a competition here for a minute.
No, not at all.
Oh,
I'm the one and only, right?
The competition is yourself.
All right, it's all mine.
Okay. All right, we're shifting, folks. It is February 11th, 2/11, get it? 2/11.
That's fine.
So, a couple of different things. This is, one we wanted to hear specifically and congratulate you on your 20 years in service. It's a big milestone. And I remember being around when, we were just thinking about 211 and whether it was really going to work or not. And I'm like, yeah, 20 years later, it is. It's working later. Welcome to our committee. Thank you so much. And Elizabeth, this is the first time you've been in committee this year, I think. Why don't we just do a quick around the table? I'm Teresa Wood from Waterbury. I also represent Bolton, Buellsboro, and Huntington.
Ann Donahue from Northfield, also represent Berlin.
Hi, good afternoon. I'm Dan Noyes. I represent Woolkit, Hyde Park, Johnson, and Belvedere.
Hi, good afternoon, Representative Eric Dwyer, Rutland City.
Representative Seti, East Milton, Westford.
Dick Bishop, representing Colchester's Chittenden Planning District.
Hi, Todd Nielsen. I'm representing Brandon and Forest.
Hi, my name is Zon Eastis. I represent Guilford and Vernon.
Hartford.
I'm Jubilee McGill. I represent Bridgeport, Middlebury, New Haven, and Weybridge.
And I'm Ray Garofano, Essex and Essex Junction.
I'm Lori Morris, committee assistant. Do you need the Zoom link?
Are
you planning to share anything?
Yes, Lori, I sent you a PowerPoint. I'm going to resend the correct one. I sent you a draft. I apologize.
Okay. In order for you to show it, you need to join the Zoom meeting. So I'm going to send that link to you right now.
Oh, perfect. Thank
So
you.
we're first doing business.
That's okay. We'll just continue around the outside.
My name is Helena Van Horst. I'm the executive director of United Way of Addison County. And I sit on the board of United Ways of Vermont. Beverly Bowman from the Vermont Early Childhood Advocacy Alliance. I'm Clarissa French, executive director at United Way of Vermont County and the board chair at United Ways of Vermont. I'm Carrie Stiller. I work for Vermont Food Bank.
Amy Shoulder here today as lobbyist for the Food Security Roadmap Coalition. D11 is a priority.
And Emma Paradise with Common Good Vermont, which is a statewide program of United Way of West Vermont.
Thank you. Whenever you're ready.
Yes, thank you very much. I'm sharing, I'm logging into the Zoom link. Thank you all for having me here today. I really appreciate your time. I know that you had a full list of things that you're trying to get through today. And thank you so much for celebrating Vermont 211 with us. And for the recognition on the floor, thank you very much, Representative Wood. Appreciate it. So I'm hopefully joining Lori.
You're joining, it'll just take a sec to give you a co-host.
Do I need to join with audio?
If you do,
You'll make all sorts of weird.
I don't want to do that. That's why I asked. Because I don't want to do that to you.
Yes.
Yep, and you guys will just be listening to me in really deep stereo. Okay. And I'm the host, or I have sharing.
You do?
Thank you. I apologize for my technology. It's here. Share.
Right, you're doing it faster than some people.
Am I?
Yeah.
That is very
Yeah.
encouraging. Thank you. Slideshow. Beginning. Is it sharing? No. I think I'm just going to read it. I think my technology struggles is not happening. So, we have a draft. You could follow it along, and I'll send the original. Thank you so much.
Okay.
So I thought today I would just level set a little bit about 211 to make sure that everyone understood who we are and what we do. So as we've been talking about, this is the 20th anniversary of Vermont 211. Back in 1999 was a conversation about some centralized information referral system in Vermont. And then we were founded 20 years ago and partnered with the state of Vermont to do disaster work as well as support for the Agency of Human Services. We are a free and confidential information and referral system for the state of Vermont. And what that means is people can reach out to us by phone, text, or email, and we connect folks to Health and Human Services, both on the local level as well as the statewide and national level. Folks are welcome to call us 24 hours a day, 7 days a week, every day of the year. We're here to help people connect. We promote the health and well-being of Vermonters through this statewide information referral system. It's a streamlined access for folks. And we are the only statewide information referral system in the state of Vermont. We also hold national accreditation with Inform USA, which also provides certification to our staff as well as accreditation for our database and our agency. So what that means is that it is a profession with standards, and we follow those standards to make sure that we have the best information and the best connection for Vermonters. A little bit more about us. We are part of a 211 national system. As part of that network, we share data and information as well as best practices. We are part of the United Way network as evidenced by some of my colleagues who are joining us today in support of Vermont 211. We have trained community resource specialists who answer the phones and the texts and the emails, and they are more than just folks there to give out phone numbers. They actually offer support to callers. They brainstorm with callers. They pass forward any gaps in services or resources that aren't existing in a region, because we all know that everything is not always equitable as much as we want it to be across the state. We also have certified resource database specialists who spend their time maintaining, vetting, and updating that database, which has over 1,000 agencies, over 3,000 programs, and over 11,000 services for Vermonters to access every day, both online as well as by reaching out to us directly. And again, you can call, you can text the zip code, and you can also email us online. We're also part of the emergency GA housing process. We cover the Agency of Human Services emergency housing intake process Monday through Friday from 4:30 to 8 a.m., as well as all day on weekends and holidays. So when their business offices are closed, we're helping connect folks to housing. I know that's a big topic for everybody here when it comes to emergency housing and shelter. I will say that we have seen our numbers rise dramatically over the last couple of years. Currently, over 50% of our calls are for shelter and housing. It is very taxing to our staff. I actually had a staff person tell me that her concern was that Vermont 211 was becoming the face of no when it comes to housing and shelter in the state, because there are so few resources and so few places to send people. Even within that emergency housing system, on any given night, there are not enough hotel rooms for the families that we're serving. So to kind of give you an idea of what that looks like, in December of 2023, we handled over 5,000 calls for emergency housing and shelter. And this year we handled over 7,000. That's just in the course of a year. We served 2,000 more people just for that during those hours of the program when we were covering emergency housing.
I saw hands go up on both sides, Representative Easties.
Okay, thank you. Well, could you just describe quickly, say I need help and I call 211, what happens when I am looking for housing?
Are you calling during, when we're covering for ESD, or are you calling during the day?
Let's say calling
If you're calling at night, because we are contracted with AHS, with Agency of Human Services, we have access to their computer programs. So we use GAPS and Access, which are the programs they use. We go through their process of asking their intake questions to see if you would qualify. If you did, we would then look in your region and see if there were any hotels available for you. And then go through that process with you. You know, can you get there? Do we need to call the motel on your behalf and say you're coming at this time? We try to make sure you're going to get there so that there aren't consequences for you if you don't make it. If there are no rooms available and is no shelter available, then we direct you to call ESD in the morning, which means that overnight there is no place for you to go.
Okay.
Yep.
Just looking to confirm that I understood those numbers correctly. Can you repeat them again just for the month of December or year ending December for those 2 years?
Just for the month of December.
Just for the month of December, and just related to housing
During those after hours.
during the after hours?
Yeah.
So 5,000 to 7,000.
Representative McGuire.
Your total contacts, are they unique contacts, meaning one time, or are they duplicates?
They're duplicated. Yes, and we always encourage people to call us back, especially if they try a resource and they're told by that resource that they can't access it for whatever reason. We want them to call back so that we can try to brainstorm with them.
Do you have any idea what that duplicate number would be?
I do not.
Sorry, so in a best case scenario, or in case scenario, you might supply someone like me with a list of 6 different places or something like that. But then I would 6 different options, possible housing options, and that counts as the duplicates.
If you called.
Yeah.
No, that would be one-time call.
And I would get.
And you would get multiple referrals. Yes. So our referral numbers would be different than our call numbers.
I see.
So last year in 2024, we had over 57,000 contacts with Vermonters for resources, and we provided over 22,000 referrals. So you may call and not get a referral, especially if you're calling for emergency housing. Yeah.
I see.
Yeah.
Successful.
A successful referral. Yeah.
Representative Nielsen.
I don't want to criticize. I worked in the women's shelter last winter.
Do you have a question, Representative Nielsen?
No, then.
Okay. Right now, we're just asking.
No, that's okay.
I do want to mention, though, in talking about those December numbers, that this year, the emergency housing rules changed on December 1st. And so that drives a lot of our calls when that happens. So every time there's a rule change around emergency housing, it means that we're having to pivot and that our call volume is going to go up dramatically. It's a guarantee every single time it happens. Not only do callers not necessarily understand what the rules are or whether or not they qualify, but service providers don't either. So we encourage service providers to also reach out to us when they're working with clients. And so there's a lot of education that happens during those calls that can be challenging. Yeah.
That's it. I think that probably an important distinction that you just made. It's not only individuals who call, households who call, it's service providers also use you as a resource.
Absolutely. I would encourage all of you to use us as a resource as well. I know to you if you have questions about resources or the person needs something and you're not sure, you can direct them to us, or we're happy to speak with you as well and help you walk through that process to get the best resources.
So, sorry, then following up, learning. So I'm interested to know what authority where you rest in this entire system. It sounds to me, that this is the ideal situation for all Vermonters to have one place that they could start with and things move out, but I don't know that it works that way. And then if someone does call you, say an agency calls you and you supply names to them or cases or situations, is there expected follow-up? Is there an expectation that you follow up and make sure things are done? Or, do you see what I'm getting?
I see where
at?
you're going with that. I
Yeah.
do. And so we are information referral. Our job is to collect, vet, and maintain the best information about those health and human services and make sure that information is given to folks so that they can take action or work with their case manager to try to connect to those resources. And we're always here that you can come back to the well if you need new ones or if you have questions about it. And when we talk to folks, we really give them this robust information. It's about the description and what you need to go there, trying to set you up for success. But at the end of the day, that results-based accountability is really whether or not that agency was able to provide that service to the
Right.
client.
So-
We're trying to drive them.
Yeah, so you're dealing with two sides. You're dealing with
Yes.
the Vermonter, and then you're dealing with
With the
the service
agency.
agencies. And so I'm trying to get it, I want to
Right.
make sure that there's good connection.
Yes.
And that, yeah.
In terms of the resources, because we follow those national standards, we update that agency's programs and services a minimum of once a year, usually more often as things are constantly changing and maybe they have funding changes. So our database is a living thing. So it's always changing and growing. And that's how we try to make that best connection, is through that updating of the database and then pushing that information out to Vermonters and service providers so they know where to go and they're not spending all of their time Google searching on websites that maybe haven't been updated. Yeah.
Rep Noise, and then we're going to let Elizabeth finish out, and then we'll try to make sure we have a little bit of time for questions at the end.
So as we know of different agencies or supports in our communities, are you the person that we reach out to make sure that you have the most up-to-date?
I would love that.
Great.
That would be fantastic. And then I would be happy to connect you to our resource program manager, Adam, who is the one leading that team. But I would love to be that bridge. That would be fantastic.
I want to make sure you have an opportunity to get all the way through your information. So we're going to hold off questions.
Also, I'm here from 4 to 5 for dessert in the cafeteria, if you like. And there's cookies. That's the carrot, right? That's cute. Our top 10 referrals in 2024, not surprising, as I mentioned, housing and shelter far blows out of the water. Any of our other services. Tax organizations are often second because we do scheduling for VITA tax services for CVOEO during the tax season. Disaster services has risen to the top because of all of the flooding. I'm going to talk a little bit about our disaster work. And of course, utilities, right? That's always in the top 5. It's always a struggle. We do spend a lot of time with folks talking about if they've exhausted those utility resources. Is there a way that maybe, if you apply for 3 squares, you could divert some money towards fuel? That's the kind of work that 211 is doing in those phone calls, trying to help Vermonters navigate systems and understand the best way to access what they need and still have those basic needs met. I do want to mention that if folks are interested in our data on Vermont211.org, we have a whole page dedicated to both current data, archived data. Our emergency housing numbers are on there. You can go in and look at past newsletters as well. So it's a great resource, as well as national 211counts.org, which is where 211s across the country and Canada do an impact every year. We just did ours, and it goes into that database, and you can compare Vermont to other states if you'd like, as well as look at your own county level data. So to talk a little bit about what happens in times of disasters and emergencies, Vermont 211 is really that central place. Again, we're the one number people can call and get information. We have been that face of emergencies, both through H1N1 and Irene and COVID and the 2 floods. Our role in disaster is to get out to the public information about relief services, such as shelter and food. We do rumor control. We work with emergency management and AHS to ensure that we have the most recent relief resources in there, and that is a constant moving target, we know. So sometimes that requires us making changes in the middle of the night to resources, depending on what's happening. We provide that comfort and assurance to people who are scared and concerned and don't know where to go. We are a place where folks can report their damages when there is flood or ice storms or other issues like that. We help to identify gaps in services to make sure that we're bringing that forward. If we see something that we're getting a lot of calls about and there's no resource or need there, we want to elevate that. And we also critically are fielding non-911 emergency calls during disaster. That preserves the integrity of 911 emergency services. So instead of those lines being clogged, we're the number to call. And then when you have a true crisis, like a real emergency, you can call 911 and those lines aren't being flooded in times of disaster. I want to pause can I pause for a minute and see if anyone has questions about disaster? Should I plow on through?
Why don't you plow on through?
Okay.
Because you just got a couple other slides and then we'll have a few minutes at the end for questions. Perfect. And Rep Cole will be the first.
I saw her peripherally, so I want to remind folks, all calls are confidential. We offer telephonic interpretation to folks who call us and are non-English speakers. We have an IVR system where when people call 211, they can choose to go directly to 211 or Help Me Grow Vermont, which is one of our partnerships. Or at this time of year, you can have your own pathway to VITA scheduling. And we also have an extension for economic services. So people call 211 and they hear, oh, this is a direct path to ESD. They can choose that and it's a warm transfer to their benefits line. So we're trying to help drive those calls instead of having people call us, hang up and call again. They may hear that and say, oh, that's what I want. I need help with that. Our community resource specialists collect very basic data during calls. If folks are willing to provide that information, it is really age, gender, county, town, except during emergency housing hours, in which case they complete the state intake. And that data is only used for demographic purposes and reporting. All of our calls are recorded for both quality improvement and as well for staff training. And we also, staff use their training when they get a caller to really talk about what it is that their needs are, what additional needs they might have, what resources are available, what the next steps are, strategizing around those resources. It really is an art form, and our staff are just highly qualified and empathetic listening ear for Vermonters. And then finally, I want to talk a little bit about funding and sustainability. I think folks know that Vermont 211 has received generous support from the legislature in the past, and we're very grateful for that. I think people assume that 211s are a well-established public program. And so because they think that there is just this support structurally for 211s, not just in Vermont, but I think across the country. And the reality is that that does not happen in a consistent way for most 211s. It is a constant struggle, and we are tied to the state. We support the state. And so when we are not provided accurate funding for operational costs, it means that it affects the way that the state does business as well. We saw in the budget this year that the governor has us level funded at 1.3 million, which is what we got last year. And we will be making an ask this week for the 332,000 to bring us back up to our operational costs of 1.6 million. Without that, it will impact our 24-hour service and our staffing and our ability to plan. So putting a little plug in there. again,
And
want
that comes through DCF or AHS central office or where?
AHS. Again, I do want to encourage you to reach out to 211, either with for constituents or on your own, or if you just have questions, we're always happy to talk with folks and answer questions and help you better understand the resource landscape in your region. If you're wondering what's available for certain areas of need, or how many people are calling us, or what kinds of referrals that they're asking for, we're happy to provide that as well.
Thank you, Elizabeth. Appreciate it. And she did provide a link to her monthly report in the PowerPoint. So I suggest people check it out. Rep. Cole.
Thank you. Yeah, I love those monthly reports. Are very helpful and insightful to see what's going on. My question, I have a couple, but one is, what is your intersection with 988 and how do you interact there? And I know that you guys are a confidential service, but I'm curious about mandated reporting rules and how those govern you or don't govern you.
Yeah, those are great questions. We, for up until very recently, were the database for 988. So we had built a database within our database specifically for them to support their work. Quite a few years ago, 211 actually answered suicide prevention lifeline calls. And when 988 came into existence and those calls transferred there, we built out a database for them and that they were using. They recently switched over to the national database, but we do continue to be close partners with them. And we do warm transfer them to 988 when folks call in crisis.
And then for mandated reporting, how does that work for you?
All of our staff do mandated reporter training. I would say that 211 staff have had to call 911 services before for clients who maybe were not willing to utilize emergency crisis services. It doesn't happen too often. In terms of reporting abuse and neglect, I would say Help Me Grow is probably the agency that does that the most. 211 has not done that very often, but they are trained and we do require it. Yeah.
Thank you. And then staffing, alongside your budget requests, I'm just curious about how that's going for you. I mean, being 24/7 available, I can imagine how hard that must be.
Staffing is challenging. We have a great team right now. They've been stable. Our staffing at the contact center has been stable for about a year now, which I know probably doesn't sound like much, but it actually is a huge achievement. It's very easy to burn out in this job. And it's also very difficult to get somebody to the end of training who is still feeling like they have the skills and want to continue to learn and do that work. It can be very thankless a lot of the time. They take the brunt of people's emotions a lot. But we do have a solid team, and we do also contract with New England Contact Center in New Hampshire to support us with some of those after hours times.
Thank you.
Last question, Representative Bishop.
Thank you. This relates to disasters. And looking at two of the things on the list of your role, manage and tracking available resources, which can be very fluid during the time of a disaster and quickly evolving. And then also sort of identifying the gaps and potentially also taking damage information. Do you get supplemental funding or support or staff during those times of disaster, or do you have to do it within your existing budget?
We have had to do that within our existing budget. We are currently working with emergency management on contracting and finding a way to get some support. And in terms of volunteer, in the 2023 flood, we had a tremendous support from the 211 network in other parts of the country. That's one of the benefits of having a 211 in the state is we have this national support that will come to each other's aid when events like that happen. So we've been fortunate in that respect.
Rep. Nielsen, did you have a question?
No, she answered. I'm fine. Thank you.
Okay, all righty, thank you. Elizabeth, thank you so much for being here, and thank you for everything that you do and with the support of United Ways. That's awesome. I think we're fortunate to have 211 in the state, and fortunate to be able to have such an established program that helps so many Vermonters. So thank you very much for everything that you do. And just as an FYI, Rep. Cole and Rep. McGill would be the budget contacts for you for making your case, and then they'll make recommendations to our full committee.
Great. Thank you so much. Thank you, everyone. Okay, and please reach out with questions.
Thank you. Next committee, we're supposed to be taking up the health department budget. I'm not sure if the commissioner is outside.
Watching him.
Okay, so he's still room 10, so you have just a few moments to take a quick break, and we can go on.